This is a case of the case in the aortic intervention. We did a successful endovascular treatment of a very long segment total occlusion of abdominal aorta in a patient who was not a very ideal candidate for a major surgery. Dr. Michel he has said in his lecture that the surgery in the infrarenal aorta also carries significant morbidity and mortality. So endovascular treatment was a good choice for this patient who is not a ideal candidate for surgery. He is a 51-year-old patient. He was suffering from schizophrenia he was on medical treatment for same for the last 7 years. And he had hypertension and diabetes and he was on treatment. And he came with severe progressive claudication of both thighs and legs in the last 1.5 years. He had no angina. Angiography showed single vessel coronary artery disease and he was advised medical management for same. And we found on angiography total occlusion of the infrarenal segment of the aorta with collaterals that was feeding both the femoral arteries on either side. The technique and the hardware that was used was we obtained access from 3 sides. From bilateral femoral access were obtained and sheath were put in, and also left brachial percutaneous access was obtained. We put a 7 French sheath and we crossed the total occlusion of the aorta from above from the brachial access site, because we tried from both sides in the femoral and we could not cross the total occlusion from either side. So we went in from the brachial approach and crossed the total occlusion 2 times and then came into both the femoral axis. This wire which was crossed from above was exchanged for an Amplatz super stiff wire through a small 4 French catheter which was passed from the femoral sheath, and the same technique was repeated on the right side. And the aorta was dilated with 2 balloons placed in parallel by a kissing balloon technique. And there was, after the balloon dilatation, there was a dissection in the aorta, and this was stented using a 16 by 40 millimeter wall stent. And 2 stents were also placed from the stent in the aorta that were leading on to the both iliac arteries, and which was overlapping with the stent in the aorta. And the post dilatation was done by using a kissing balloon technique to open from the aorta into both the iliac vessels, and final angiogram showed a very well positioned stent in the aorta and in the iliac arteries. I'll show the pictures. This is the angiogram from the right femoral sheath, which shows there is a total occlusion of the iliac artery at the origin, and we tried crossing this during the intervention and we could not succeed. And this is an angiogram from above. From the brachial side we are injecting in the aorta, that is to show that the renal arteries are taking off here. There is a total occlusion of the infrarenal segment of the aorta, and you can see the right iliac is occluded simultaneously. Dye is being injected from here, and you can see there is no iliac artery. This is a huge collateral. So even the left iliac artery is totally occluded. We tried crossing. I am not showing those pictures. We tried crossing from below on both sides, and we had dissections in the right femoral and right iliac as well as in the left iliac. So we tried crossing from above, and you can see this is a Terumo wire 035 which came up crossing the total occlusion of aorta, and it is being retrieved from the femoral sheath on the left side by using a gooseneck snare. You can see it being pulled out. And from here we put in a 4 French catheter into the aorta and took out this wire and exchanged for a super stiff wire. Now we have a super stiff wire going in here. The same technique was used for the other side, and we crossed from above again and retrieved the wire by using a gooseneck snare into the right femoral artery, and this was exchanged for a super stiff wire. So now we have across the totally occluded segment of aorta, we have 2 wires going on each side, and we placed a 2 long 8 by 40 millimeter balloon on either side and did a kissing balloon dilatation at the total occlusion of the aorta. You can see both the balloons are being dilated at the same time. This is the angiography from above after the balloon dilatation that shows a connection between the aorta and the 2 iliac arteries, which was originally occluded. And then we placed a stent in the large size stent in the aorta, 16 by 60 millimeters, taking it from one of the wires on the right side. Now you see when the stent is being deployed, this wire is going to be lying outside the stent in the aorta. And then post dilatation was done using a large size balloon, and the stent was well opposed to the aorta. You can see this, because the stent is deployed from one of the wires, the other wire is lying outside the stent. And then this wire had to be pulled out and then crossed again from below into the stent, and then the two wires are lying inside the stent now. And then we took two balloons and did a kissing balloon dilatation to deploy the stent well at the distal end of the aorta. And then two stents had to be placed in both the iliacs, overlapping within the stent in the aorta. You can see that it is lying within the stent in the aorta, and the connection is being established into both the iliac arteries. This is the final result after both the stents in the iliac was deployed. And then again kissing balloon dilatation is being done to oppose the stents well with the stent within the aorta. And this is the final angiography at the end of the intervention. So the lessons learned from this case are: there is a feasibility of treating a long total occlusion of the aorta, infrarenal aorta by endovascular technique, and it is quite possible, and you can do it well. And the challenge only was in crossing the total occlusion. Here the occlusion could not be crossed either from the right side or the left side, though we spent a lot of time trying to cross from below, we couldn't achieve it, and then we obtained a brachial access and then crossed 2 times from above, and then the wires were retrieved from the femoral artery. The wire I told you from the left side, because the stent was deployed from the right, it was jailed with outside the stent, and this had to be retrieved and recrossed again before we could finish the kissing balloon technique. Thank you.
Thank you, Dr. Lakshmi. This presentation is open for discussion. Any questions from the fellow panelists or from the audience? Any comments, any suggestions?
Surgical option was not considered in this? Yes, this patient I told you was schizophrenic. He was very afraid to undergo even an angiogram. He was having claudication for almost 1.5 years, and he never presented to the physician with a complaint. And finally, he landed up with us with the history. And then on examination, we found it was occluded, and we knew the occlusion is going to be above. Even to take him for an angiogram was a great task to convince him to come to the cath table. So it was kind of a ad hoc procedure. We did the angiography followed by stenting in the same procedure.
That was the question from Dr. Dhar. How did you manage to keep him quiet for the time that you took? Did you use IV haloperidol? Did you use anesthesia?
Sedate him.
For a surgery, that would have been better. You could have given a general anesthesia, no schizophrenia, nothing.
In fact, he came for the initial follow-up with the relatives brought him. After that, he is not even coming during the initial follow-up, he came after 6 months. This was done some 2 years back. And bilateral pulses were felt well, and he was doing very well clinically. And he has not come for longer term follow-up actually.
Professor Michel has a question.
Yes, do you think there is a role for fibrinolysis in that case? Because sometimes when I have a case like that, I give fibrinolysis. Sometimes I have the impression of we can soften a little bit the plaque. But we can soften a little bit the occlusion. Do you think there is a role for thrombolysis?
Thrombolysis, yes. With Dr. Michel is our teacher. We have learned all the interventions from him and Mrs. Hugel. And whatever we are doing today is will attribute to his teaching. And we have used thrombolysis in some patients and before opening the total occlusion. But in this patient, we didn't use it because we did it as an ad hoc procedure. For this patient, we have kept him on dual antiplatelet therapy.
But one of our stent follow-up shows that one rim of that Y is gone, the other rim is functioning. We thought if we had coagulated fluid, we would have done. The second question was the stent in the aorta. You have been the balloon expanded the stent, and then you join the legs from the either side.
Yeah, this was a self-expanding stent. Yes. Yes. Definitely, yes.